Today, we are going to walk through the complete anesthetic approach for patients undergoing thyroid surgery, and more importantly, understand the clinical reasoning behind every step, just like you would think in a real operating room or exam scenario. Thyroid surgery is unique because it involves a shared airway, critical neurovascular structures like the recurrent laryngeal nerve, and endocrine physiology that can significantly impact hemodynamics. So, every decision we make as anesthesiologists is precise, calculated, and aimed at maintaining safety while optimizing surgical conditions. Let us begin with the preoperative assessment and optimization, which is arguably the most crucial phase. Before even thinking about anesthesia, we need to evaluate the patient holistically. Start with comorbidities, especially cardiovascular, respiratory, and metabolic conditions like diabetes. Thyroid disorders often have systemic effects, so ignoring these can lead to intraoperative instability. Next comes a focused thyroid assessment. We must determine whether the patient is euthyroid, hyperthyroid, or hypothyroid. This is critical because operating on an uncontrolled hyperthyroid patient can precipitate a thyroid storm, a life-threatening emergency characterized by severe tachycardia, hypertension, hyperthermia, and arrhythmias. Therefore, we always review thyroid function tests, T3, T4, and TSH, and ensure the patient is optimized, often with antithyroid drugs and beta blockers if needed. Airway assessment is another cornerstone. Large goiters can cause tracheal deviation, compression, or even airway obstruction, making intubation challenging. So we must anticipate a difficult airway and be prepared with advanced airway equipment. Medication review is equally important. Many patients are already on antithyroid medications or beta blockers, and these should be continued appropriately. Additionally, since thyroid surgery can affect calcium regulation via the parathyroid glands, we also ensure adequate calcium and vitamin D levels preoperatively. The overall goal here is simple but critical. Achieve a stable euthyroid state, identify airway challenges early, and prepare for metabolic and hemodynamic fluctuations. Now moving on to anesthesia techniques, where planning meets execution. The standard approach is general anesthesia with endotracheal intubation, primarily because this is a shared airway surgery. However, this is not just any intubation. A key advancement in thyroid surgery anesthesia is the use of a specialized endotracheal tube with EMG-based nerve monitoring capability. This allows continuous monitoring of the recurrent laryngeal nerve, which is at high risk during thyroid dissection. Injury to this nerve can lead to vocal cord paralysis, which may present as hoarseness or even airway compromise postoperatively. In addition to general anesthesia, we often incorporate regional anesthesia techniques, such as a cervical plexus block, as part of a multimodal approach. This significantly reduces intraoperative and postoperative pain, allowing us to minimize opioid use. The reasoning behind this approach is very practical. Secure the airway in a controlled manner, provide optimal surgical conditions with immobility, and simultaneously protect critical neural structures through real-time monitoring. Next, let us step into the operating room and discuss intraoperative management and specific monitoring, starting with patient positioning. The patient is placed in a supine position with neck extension, often referred to as the sniffing or rose position. This positioning helps expose the thyroid gland clearly, making the surgeon's job easier. However, it also requires careful padding and support to prevent nerve injuries and ensure patient comfort. At the same time, we must maintain easy access to the airway, since any sudden swelling or complication could compromise ventilation. Now, one of the most critical intraoperative considerations is monitoring the recurrent laryngeal nerve. Using EMG-based monitoring systems, we continuously assess nerve function throughout the surgery. This is especially important during dissection around the thyroid gland. Alongside this, we also monitor for signs of thyroid storm, such as sudden tachycardia, hypertension, or hyperthermia, although this is rare if preoperative optimization has been done properly. Maintaining hemodynamic stability is essential, particularly avoiding hypertension, which can increase the risk of postoperative bleeding. Another key aspect is parathyroid gland preservation. These tiny glands regulate calcium levels, and accidental damage or removal can lead to hypocalcemia. Therefore, we may monitor intraoperative or postoperative PTH and calcium levels, especially in total thyroidectomy cases. The reasoning here is straightforward: protect nerve function, maintain cardiovascular stability, and preserve endocrine balance. Now let's discuss an often underestimated but critical area: key considerations and multimodal analgesia. Thyroid surgeries are not extremely painful, but poor pain control can lead to increased sympathetic activity, causing hypertension and bleeding. Our focus is on hemodynamic control and prevention of hematoma, which is one of the most dangerous complications because it can rapidly compress the airway. We aim to maintain stable blood pressure, avoiding sudden spikes. Fluid management is typically goal-directed and restrictive, as excessive fluids can lead to tissue edema, including in the neck, which again increases the risk of airway compromise. For pain management, we use a multimodal, opioid-sparing approach. This includes acetaminophen, NSAIDs, local anesthetic infiltration, and sometimes intravenous lidocaine infusions. The advantage is reduced opioid consumption, which means less nausea, less sedation, and faster recovery, aligning with modern era's enhanced recovery after surgery principles. Finally, we move to the postoperative phase, where vigilance is absolutely critical. The first priority is monitoring and recovery. One of the simplest yet most effective assessments is asking the patient to speak or say their name, which immediately gives us an idea about vocal cord function and possible nerve injury. Next, we assess for airway obstruction, which can occur due to neck hematoma, swelling, or bleeding. Signs like stridor, difficulty breathing, or neck tightness should never be ignored. They require immediate intervention. Another important parameter is calcium levels. Since parathyroid glands may be affected, patients are at risk of hypocalcemia, which can present as tingling, muscle cramps, or even tetany. Therefore, we monitor postoperative calcium and PTH levels closely. Pain management continues in a balanced way, and we also address postoperative nausea and vomiting, as vomiting can increase neck pressure and risk bleeding. With advances in surgical and anesthetic techniques, many thyroid surgeries now follow day care or early discharge protocols, provided the patient is stable. The reasoning behind all postoperative monitoring is to ensure early detection of complications like hematoma, nerve injury, or hypocalcemia, allowing prompt intervention and safe recovery. To bring everything together, the anesthetic management of thyroid surgery is a perfect example of precision medicine in action. Every step, from preoperative optimization to postoperative monitoring, is guided by anticipation, prevention, and rapid response. We are not just giving anesthesia. We are actively protecting the airway, preserving nerve function, maintaining metabolic stability, and ensuring a smooth surgical journey. So, whenever you think of thyroid surgery, remember this framework: optimize the patient, secure and monitor the airway, protect the recurrent laryngeal nerve, maintain hemodynamic stability, and vigilantly monitor postoperatively. That is the essence of safe and effective anesthetic care in thyroid surgery.